second talk, Dr. Ahmed Elsisi from Matariya Hospital.
Alright. Good evening. I'm Ahmed Elsisi, lecturer of nephrology in the National Institute of Nephrology and Nephrology.
يا احمد انت اشهر من نار على العالم دلوقتي، احنا عايزين ننتخبك كلنا
الله
دلوقتي.
يخليك يا ربنا يخليك. And I would like to thank the Egyptian Society of Nephrology and Transplantation for the kind invitation on behalf of myself and the National Institute of Nephrology. This will be less than 20 minutes, I hope. And I would like to welcome the international faculty that are, we are very much honored by their presence. About this case, it's about this 24 years old gentleman who was suffering end-stage renal disease.
المونيتورز مش شغاله هنا يا بنتي. المونيتورز مش شغاله.
Okay. I think that it's a little bit dramatic, the catastrophic post-renal transplant course, and at the end it was nice. The background data of this gentleman is a 24 years old gentleman who suffered CKD stage 5 on dialysis since June 2013 with unknown original disease. He is planned for transplantation donated from his sister with 3/6 mismatches with conventional immunosuppression, as he is considered low immunological risk, based on steroids, cyclosporin, and MMF. And this is the first slide, actually. هو في مشكلة في المواد؟
حط الساعة.
مش مهم الساعة، نخلص قبل الساعة.
طب شغال شغال الريموت، اشتغلي بالريموت يمكن تبان بالريموت.
Okay, I think I'll continue until the technical problem is there. So he's planned for transplantation from his sister with 3 mismatches, and he's considered low immunological risk, so he's planned with for steroids, cyclosporin, and MMF. And I said that the original disease is not known. He had his smooth operative course with immediate diuresis and the total ischemia time. Okay, the 24 years old gentleman, CKD stage 5 on dialysis in July 2013 with a known original disease. Body mass index was 23 and dry weight is 63, irrelevant family and past history. He's planned for transplant from his sister with 3 mismatches and negative serial cross-matching, including flow cytometer cross-match. He's considered the low immunological risk with triple therapy, including cyclosporin, MPA, and steroids. Smooth induction of anesthesia and operative course. Ischemia time was 40 minutes with immediate diuresis. However, he had a very difficult extubation, tongue and laryngeal edema, and recovery from anesthesia, which required about 3 hours till transfer to the ICU. Upon transfer to the ICU, the patient required, during recovery, 240 milligrams of furosemide to maintain 3 liters of negative balance to be saturated. He's transferred to ICU at 7 p.m. while the operation ended at 3 p.m. His respiratory rate was 32, the mean arterial blood pressure was ranging from 75 to 95, and the pulse was 75 to 85, and the CVP ranged from 5 to 11 centimeter water, and the ABG showed picture of acute lung injury. The patient This was the X-ray, the first X-ray done post-operatively. It was not very significant. However, also in the post-operative course, the urine output was 10 liters in 11 hours in a descending manner, and fever started rising from 10 p.m. with maximum of 38.3 at 6 a.m. in the morning, day plus 1. Chest examination showed scattered rays and bronchi, mainly inspiratory. While during the ICU course, the gentleman was ventilated at 11 a.m. day 1 with difficult intubation when his respiratory rate exceeded 40 and the alveolar oxygen concentration went down to 52 with full-blown picture of ERDS. Of course, to those young generation that's not oriented with other respiratory distress syndrome, it carries mortality in the United States ranging from 80 to 90%. So this is a transplant, a young transplant, 24 years old, donated from his sister with an ARDS. The primary management of ARDS relied on reduction of immunosuppression, starting meropenem, metronidazole, levofloxacin, fluconazole, covering our provisional diagnosis. Of course, we don't know yet why this ARDS have occurred. And this is the X-ray done at day +1. Of course, I will not describe the X-ray, it's very evident. Well, we had a provisional diagnosis ranging from aspiration pneumonia and ventilator-associated pneumonia. However, the ventilator-associated pneumonia was very remote because in our institute we do the transplants in the beginning and the ventilators of the anesthesia is sterilized twice versus a negative pressure pulmonary edema with consequent acute lung injury and ARDS. The management of ARDS, including ventilator recruitment techniques, and I think that this exercise physiotherapy that we've done in the institute is new, I think, in the world. Most of those patients are critically ill. This young patient was very fit, so we started him on walking while ventilated. He was ventilated, and we started him walking in place while ventilated. And we maintained a negative balance as possible. Of course, thorough follow-up for acute phase reactants, oxygen requirements, and serial X-rays were done. Of course, there's many variables during the course of the hospitalization, so I put some of the variables to describe it in brief for the sake of time. And these are the days from 0 to 6. And this is the body weight. The variables is the body weight, the output, the temperature, the C-reactive protein, steroid and MPE dose, and cyclosporin, which was given as an IV formulation, and the central venous pressure. At day 0, he had 10 liters, and the temperature was 37.5. At day 1, his body weight is 69, and we said that the dry weight is 63, and the urine output dropped to 2,650 cc's for the 24 hours, and the fever reached 38.5, and the CRP was 38. We minimized at day 1 the steroid dose to 125 milligrams, and we minimized the MPE dose to 540 BT. The CDP was 8. At day 2, the urine output still a little bit oligoric, 3.5 liters. The body weight went to 68. The fever is more or less controlled, 37.5. So we increased the solimedrol or the methylprednisolone dose to 250 milligrams, and we kept the MPA and the without cyclo IV, and the MPA is 540 BD. The CDP went up to 15. At day 3, the urine output improved to 5 liters. The temperature is more or less controlled, 37.3 in the maximum, while the C-reactive protein went to 106. So we kept a low steroid dose of 250 in day 3, and we didn't introduce any CNIs. And here we can recognize that the CDP is rising. At day 4, the CRP went down to 64, so we increased the pulse to 500, and we introduced 50 milligrams IV cyclosporin TDS, and we maximized the MMPA to the maximum dose. At day 6, the general condition of the patient was remarkably increased, and his creatinine went down to about 2.8. He's afebrile, and we are now on 300 milligrams cyclosporin IV as a total dose per day, and the CDP is 10. And then the gentleman chest and ventilator parameters improved dramatically and was due for extubation. So he was extubated, however, unfortunately suffered stridor, glottic edema, and severe bronchospasm, and was re-intubated with difficulty. And this is the X-ray before the extubation. Of course, before extubation, the ABG was perfect. So this is another course variables from day 7 to day 12. Day 12 was the discharge. At day 7, his body weight is 65, reached his dry weight. Urine output improved 5 liters. Low-grade fever. His CRP is almost normalized. At day 7 was 20, and at day 10 was 10. The solimedrol was in tapering, and we are giving cyclosporin IV 100 milligrams CDS, and the trough level was about 90, while the MPA was in the maximum dose. Well, at day 9, we are trying to extubate the patient again, and at day 10, we shifted him to the oral cyclosporin microemulsion. Well, at day 10, another trial of extubation with humidification, antihistaminics, epinephrine, and hydrocortisone with the same previous scenario without any improvement with management steps. So the intensivist decided not to re-incubate the patient, and he put him on non-invasive ventilation, and in 12 hours the patient improved and there was successful weaning. He's discharged with base creatinine 1.8 milligram per deciliter with excellent chest parameters and normal ABG. But before discharge, I had a thorough history taking and family history with the specific leading questions that led us to a clear diagnosis. So, any ideas in the floor about what happened? Of course, he is suffering aspiration pneumonia. This is our provisional diagnosis, and he went to ARDS, and he improved. But whenever we are trying to extubate the patient, he's suffering these events: stridor laryngeal edema, and then he goes to re-incubation. So I'll continue. Of course, this is not a nephrology case. It is a little bit different. It's a little bit different. Yeah, that's why I know that most of our professors and colleagues are speaking about rejections and acute tubular necrosis and drug-induced problems. So this is something else. Yeah, I think it will be very interesting. So تراف ليفل على ال 250 مللي جرام دي اي دي لو كان 130
المفروض الاي في تبقى اورال دوز يعني
حضرتك الجرعه لما ابتدت 50 مللي جرام 50 مللي جرام اي في دي اس وبعدين عملنا ليفل وبعدين 100 مللي جرام تي دي اس وبعدين لما قلبنا على الاورال خليناها 250 دي بي وبعدين رفعنا 300 مللي جرام دي بي على الليفل ليفلز يعني احنا جايين بالليفل 300 ديلي 150 ديلي اي في الاول وبعدين 150 مللي جرام بير داي لا مش سنجل دوز لا 300 توتال دوز اي في 150 يس اي في توتال دوز بير داي
ما ده انا بقول لك عشان كده كتير
الليفل كان 130 الاي في سايكلوسبورين هنا is not a micro emulsion هو انا عارف حضرتك بتتكلمي على الفورميليشن between the IV and the oral form ده على النون مايكرو السيفايد سايكلوسبورين انما المايكرو emulsified cyclosporin it's a little bit different. Okay. We had a clear diagnosis and he was readmitted in 45 days for stent removal. يعني حاجة قريبة. Certain precautions were taken, however, not applied from the start. The same event recurred with the extubation. So, the whole process improved in 60 minutes with the management precautions. The stent, or the ureteric stent. Yes, we insert ureteric stent. So after about 1 or 2 months, we readmit the patient for removal of the stents. We have the precautions with the anesthesia. I arranged with the anesthesia to have some precautions. Of course, the previous precautions, including antihistaminics, pulse steroid, and epinephrine was unsuccessful. So this is another precautions that I declare at the end of the presentation. So after having the same event, we had the precautions and the whole process improved in 60 minutes. And the patient was discharged. So, any clues about that? We want to brainstorm. Any clues about diagnosis? We have a documented ARDS, secondary to a pulmonary cause, probably aspiration pneumonia. However, why that? Well, for the sake of time, I think just I'll proceed for the diagnosis. The leading questions, or the clues for diagnosis, the leading questions about similar events in the family was possibly in his sister, another sister than the donor, that suffered unexplained seasonal edema. Previous similar milder events in the previous 2 years in the patient, which was explained later on as uremic manifestations of the diagnosis of CKD. So he had 2 milder events, and his sister has some seasonal edema. So by exclusion, the diagnosis was type 3 hereditary angioedema. He didn't suffer this during his childhood, and this classifies type 1 and type 2. And it's not idiopathic as the rest of the investigations was negative. The laryngeal edema was probably the trigger to aspiration with the removal of the endotracheal tube with the progression to the ARDS. Type 1 and type 2 were excluded as no history during childhood and no GIT history. And idiopathic angioedema also was excluded as it did not respond to steroid and antihistaminic treatment. Diagnosis was confirmed with normal complement levels, especially C4. Precautions to confirm diagnosis was infusing fresh frozen plasma with onset of symptoms in stent removal episode. This is a picture, it's not the picture of the patient for the edema of the lips and the tongue with the angioedema. and this is a classification for the angioedema with the causes, and we are here relying in the 25% with the hereditary and acquired form of angioedema. It is very rare. It happens, the type 3 happens in adulthood, and the mean age is 26 years old. And unfortunately, we don't have in Egypt the medications, the anti-bradykinin and the anti-kallikrein antagonists that clears this. So fresh frozen plasma is the answer to our patient. Thank you very much for your listening, and this was the end of my presentation.
نشخصها النفرولوجيست ولا الانستيولوجيست؟ نفرولوجيست.
الانجيوديما او الانجيوديما حضرتك is classified يا اما ماست سيل بيست يا اما براديكاينين بيست. الماست سيل بيست دي بتحصل نتيجه البيستينجز او نتيجه الالرجيك رياكشنز، وممكن تبقى بتتعالج بالستيرويدز او بالانتيستامينيك. ما انا جاي حضرتك التايب 1 والتايب 2 ليهم حاجه اسمها انتي تريبتيز، خلاص انتي بوديز از نوت افيلبل ان ايجيبت، وده اوت اوف اور سكوب لان this is in the childhood. So this is one of two things، يا اما hereditary type 3 angioedema يا اما idiopathic. الهيريديتري هي the only one اللي بيكون معاها normal complement levels. So if you have a clinical picture and normal complement level, this confirms the diagnosis of type 3. While the idiopathic form بيبقى معاها هي وتايب 1 وتايب 2 بيبقى معاهم complement depressed level. مفيش لاب confirm.
لكن normal
complement normal complement confirmed type 3 hereditary angioedema. The only angioedema that have normal complement is bradykinin induced type 3. Type
anything other hereditary edema
there is four types. Type 1 and type 2. أفندم؟
Gene profile. To prove it or disprove it?
We don't have here. Yeah, okay, of course. There is mutations in the Hagman factor 12 recorded in these angioedemas. However, it is not diagnostic. I went through the literature.
بس أنا أقصد إنه يوديني ناحية الدياجنوز أصلا.
Well,
يعني من
criteria of diagnosis.
ممكن تبقى تروماتايز، ممكن تبقى انفكشن، ممكن تبقى وات ايفر.
الكرايتيريا اوف diagnosis you have four criteria. The clinical picture. The clinical picture includes the cutaneous and the mucocutaneous and the GIT, the age, the family history, and the complement. These are the four criteria to diagnose the bradykinin-induced angioedema. If you have a normal complement with the clinical picture and the family history, this is type 3. If it happens in the childhood, type 1 and type 2, that includes either dysfunction, type 2, or deficiency of the enzyme, this is type 1 and 2, and this happens in the childhood. So you have the remaining bit is the hereditary one, and the hereditary one, the idiopathic one, have abnormal complement. So if you have a normal complement during the attack, and the clinical picture, this type 3. We have two differential diagnoses for this patient, either the idiopathic or the type 3. So type 3 coincides with the normal complement.
Thank you very
Sorry,
much.
we need to stop the discussion. Sorry, doctor, we need to stop the discussion.
حضرتك يعني هل هو ديفلوب ARDS في اول يوم؟
اي اسبريشن يعمل
في اول يوم يا دكتور.
Dear colleagues, please, we need to stop the discussion. Thank you.
Thank you very
and
much.
move on to the